are upright. But mostly because the T waves are upright. Did everyone understand the discussion about STEMI?
No.
How many have heard the term STEMI? Okay. So let me put this in some historical perspective. There was nothing called STEMI when I was a medicine resident. I was a medicine resident from 1976 to 1979, 75 to 79, for 4 years. And STEMI wasn't a word, it wasn't anything. When someone came into our ER or our hospital with chest pain and they had injury pattern on their EKG, we said, oh geez, they're probably having a heart attack, we better put them in the ICU. We put them in the ICU and then we just watched them. Gave them a little bit of aspirin, but I'm not even sure we were doing that. We didn't do anything. There was nothing to do. They just had their heart attack and either lived through it or didn't. Well, sometimes when they would have a lot of PVCs, we would give them quinidine to stop the PVCs. It turns out that quinidine for PVCs kills people. It's a drug. It's a, huh? Oh, it's like one of those arrhythmia drugs that affects the QT interval or something. Kills people who are having heart attacks.
Just don't use it, that's all you need to know.
Don't use quinidine. So two messages there. One, in the 1970s and early 80s, there was nothing you could do about a heart attack. It just either killed you or you lived through it. Then in the early 1980s, mid-80s, streptokinase was discovered and invented and purified and made available so you could bust clots with it. And we thought, well, by that time we'd figured out that a heart attack is really a clot, a new clot in a coronary artery, and so people were starting to infuse streptokinase for heart attacks, and we thought maybe that was going to save a few lives. And shortly thereafter, someone invented the catheter that would go in and find the obstruction of the coronary artery and balloon it, and open it up. That made all kinds of sense. Let's open up the coronary artery. And if they didn't die of another blood clot, because we're really screwing around with their endothelium with that balloon, they might reperfuse their myocardium, and they might not only live through it but not have a heart attack. Might not damage that myocardium. So now all of a sudden, in the mid-1980s, we've got something we can do about a patient who comes to the ER with severe chest pain and an EKG that looks like it has injury pattern all over it. Okay? Now, that injury pattern, as we talked about the other day, is an elevated ST segment, usually in a convex way, but he showed you many of them yesterday that weren't convex, they were just elevated. And that's injury pattern to the myocardium. We better get into the cath lab and see if we can open that up. So now it's a whole different way of thinking clinically, right? Not, oh, we need to get into the ICU and put them on a monitor and see if they're having PVCs, and if they are, we'll give them quinidine. What we'll do is we'll take them to the cath lab first, open up that artery, and see if we can save the myocardium. And so they needed something to call this, I don't know who it was. He said it was 5 guys in Boston. And they wanted something to call this that raised the awareness. So they called it STEMI. ST segment elevated MI. Okay? ST segment elevation MI. That term alone is confusing because you can come into the emergency room. I didn't want to bring this up with Jacob in the room. He was too good and having too much fun. You can have a person come in the emergency room with severe crushing chest pain, ST segment elevation all over the precordium, V1 through V6, and they're not having an MI at all. pericarditis. So we're backed up. Now we're backed up. I can't call that STEMI. I can't call that ST segment elevation, MI, until I get some more information. Now, that information I get, I can get it really quick. I can draw their blood and send it to the lab for a stat troponin, and that's a blood test for a chemical that leaks out of the myocardium when it's injured. If the troponin comes back elevated, and they've got this thing that they're calling STEMI on the EKG, that's an MI. I should get them to the cath lab right now. And that's what Jacob is doing. Okay? So what you saw yesterday, you're going to see over and over and over again in the clinics next year. You're going to see clinicians thinking and responding out ahead of you. And you're going to think, boy, that's magic. That's just kind of magic. Vanatta told us it wasn't an infarct unless there was a Q wave. Okay? And if all we're doing, yesterday I said, for you, Jacob, in the ER, that's a STEMI. But if I'm reading this EKG 3 days later in the heart station, it's an injury pattern. Does that make sense to you now? What has happened is STEMI has become, for clinicians, an EKG finding. They say, oh, that's STEMI. And it's not always a STEMI. Sometimes it's pericarditis. All right. Pericarditis we can't do anything about, except put them in the hospital and give them pain medication and try to cool them off. And if you miss an acute myocardial infarction, you can let the patient die. So it's easy to see how that thought process and that behavior works. If you're an ER doctor or you're a clinician seeing patients on the front line and they come in with that ST segment elevated and they're having chest pain, it has to be an infarct until proven otherwise. It's not pericarditis until proven otherwise. You got to err on the side that'll save the patient's life. Does that make sense? Mm-hmm. Okay. Number 2. Hannah.
I got sinus rhythm, so regular. Heart rate 70, around 70. PR 0.16. QRS 0.08. QT 0.4. And then I got normal for the axis, around positive 65 degrees. And then we found the pattern tracing T-wave inversion on these 2, 3, and AVF, which are cousins, or their families. And so we concluded that it is an inferior ischemia, acute MRI maybe, and then also peak T-waves found on V2, V3. And that's all I have in normal axis.
Okay, so you called her an infarct where?
Inferior.
Inferior infarct. Mm-hmm. All right, so if they've had an inferior infarct, that T-wave business takes on a new issue, right? If the T waves are just inverted and there's no Q wave, then we've got ischemia, or we've got something. We have primary T wave changes. I'll get into that in a minute. But if there's a Q wave, there's an infarct, and we use the T waves to tell us is this acute, age indeterminate, or old. Okay? So now we have Q waves in 2, 3, and F. It's an inferior infarction. Is this acute, indeterminate, or old? Indeterminate or acute would both be a reasonable interpretation. Okay? This is not EKG truths. This is EKG interpretations. And so we're deciding whether these are ugly or sort of pretty pictures. If I look at lead, especially lead 3, what I'm looking at here is that there's a Q wave, and then there's an R wave, and then the ST segment is a little bit elevated off the baseline and is a bit convex. It's a bit convex. It's not dramatic. It's not thrown up there like that. But it's a little, and the ST segment's a little bit elevated. So I think this is pretty new. You know, there's some dead tissue in the inferior wall. There's no question about that. But this is a new infarct. If the patient came in the emergency room with some indigestion, and you did an EKG because you're suspicious, you put this person in the hospital. You put them in the ICU because this is a relatively new heart attack. When you have a relatively new heart attack, what happens is the myocardium that didn't get any blood for a while is irritable, which is why you see a lot of PVCs. And then when you're seeing a lot of PVCs in irritable muscle, you're worried that it's going to turn into V-tach or V-tip. And so you want to watch them until this stabilizes. You want to put them in the ICU, put them in the CCU, watch them on a monitor so that you can treat any arrhythmias that come up. Does that make sense? So what we call this is an acute or agent-determined inferior mod. Anyone find anything else?
There was PPR waves in V4 and V5, and there was some other things with the Estes to, I thought there was a probable LVF.
LVH? Okay, let's look back. That's a good pickup. Let's look back at the Estes scoring criteria there at the end. We started talking about that the other day, but I don't think we quite finished it. So, you get LVA, you get probable LVH if you get 4 points out of this Estes criteria. You get LVH if you get 5 points. All right, so R or S in of 20 or more in the limb lead. We don't have that. S or R in 4, 5, or 6 of 25 or more. Do we have that?
They're in V4 and V5.
In V4, it's 5, 10, 15, 20, 24. She says, yeah, okay. So we're pushing it. V4 looks a little abnormal, doesn't it? So you count it. You pay attention to it. You get points for paying attention to it. But according to the Estes criteria, it's only 24 millimeters of mercury. You don't get those 3 points. It's only 24. It says 25. Any ST segment shift. It looks like strange honey. It really isn't any. What's the axis? It's normal. No LAD. QRS of 0.09. What's the QRS? It's about 0.08. Boy, it's close to that. No tomatoes, huh? P terminal force in V1 more than 0.04. P terminal force. Okay, let me show you what that is. In V1, here's a P wave. Here's your normal QR, P, QRS, and T in V1. Okay? When you have left atrial enlargement, one of the things you have is a biphasic P wave in V1. We're going to see that after a while. Left atrial enlargement, biphasic P wave in V1. When this terminal portion of the P wave is 0.04 deep and 0.04 wide, you get 3 points. That's because when you have LVH for a long time, the left atrium is liable to get big. So you get 3 points towards LVH. We don't have any of these things. So you get positive points for looking at it, for wondering, is this LVH? And the reason is because V4 looks abnormal. V4 is tall. It's just one small box short of getting 3 points for LVH. But even if you got that one, you would only have 3 points, you wouldn't have 4, so you don't even have probable. LVH, okay, so LVH. If we worry about the patient having LVH, what test do we order? You're always going to have an EKG in front of you anyway, but what's the test? You want a picture. You want a picture of the ventricular wall because you want to see how thick it is, right? And you do that with an echo. You just do an echo. It's non-invasive, it's relatively cheap, it's easy to do, and you can actually measure the wall. All right. Anything else on this one?
Can we go with conclusion?
I'm sorry?
Can we just go with conclusion?
Who did that? Do the conclusions again?
Okay, the acute MI inferiorly on the heart indicates that it is new or in.
Acute inferior MI. Anything else? Not really. All right. Sinus rhythm. Number 3. Karen.
For the rhythm, I got sinus. For heart rate, about 100. I got a PR of 0.12 and a QRS of 0.04. A QT of 0.24. And for my axis, I got negative 40 degrees, so left axis deviation. And I had inverted R on lead 3 and ABF, so.
Okay, rather than an inverted R, it's something else. It's acute. Yeah. The first thing that happens in the ventricular depolarization curve in 3 and F is down. So that's my definition of QA. Okay?
And so I had an inferior rainfall.
Okay. Anything else? Yes.
We said that there was T-wave inversion on V1, 2, 3, and 4, and that's an anterior septal.
You're gonna have to speak up.
Oh, I said
I'm old.
T-wave inversion on V1, 2, 3, and 4, anterior septal ischemia.
Okay. Did you see the T waves?
No.
Okay. So there's T wave inversion V1 through V4. I told you that's it's ischemia, right? All right. So I'm doing the same thing with my T waves that Jacob was doing with his ST segments. Do I know this is ischemia? Not even close. Not even close. And so I was taught not to call this ischemia. I was taught to call this, and I'm going to ask you to call this, primary T-wave changes. Primary T-wave changes. So let's back up and replay how I taught this to you. I taught this to you by saying we've got a rabbit or a dog or something in the cath lab, in the research lab, and we tied a ligature around the coronary artery. And that beautiful upright T wave, the first thing it does when the myocardium loses blood is it flips upside down. Now, Jacob said yesterday the first thing it does is peak. That's probably true. But it's so short a time period, we don't usually see that. So what we say is the first thing that happens with an ischemic myocardium is the T wave flips upside down. All right. What I was teaching you is what happens in a myocardium with ischemia. Okay? What Jacob was teaching you is what happens in the ER when a patient has chest pain and they have an ST segment that's elevated. His heart rate goes up. And he says, yeah, they're having a heart attack. I got to get them to the cath lab, right? I'm saying if I see T-wave inversions, it's probably ischemia. Well, it's probably not. It's probably a primary T-wave change. And so, what's the list of things that flip T-waves? The most common is hypokalemia. Next thing is hypomagnesemia. Another thing is increased intracranial pressure. Pericarditis can do this. Okay, it's not, and so if you're in the heart station and you're reading EKGs and you see flipped T waves like we see in this EKG, you don't list the things that might be wrong. You just say primary T wave changes, and the clinician's supposed to know what causes primary T wave changes. But if you want to call this ischemia, it's fine with me, because that's the thing, that's the one thing we have to worry about. Okay? Anything else on this one? Now, how about, did it worry anyone that there wasn't a Q wave in 2? Here's a sibling without a Q wave. What do we do about that? Do we worry about it? Don't worry about it? 2 out of 3 ain't bad. If there's a Q wave in 2 out of 3, I call it inferior partial. Might not be, but it probably is. It's not a very big Q, yeah.
What if there's no S wave?
What if there's no S wave?
Yeah.
Then it's just a Q.
So is that bad? I mean,
Well, it's just, I don't know. There, in Korean AVF, there really isn't this way, there's a QS. We would call that a QS, because, you know, that, now, you think of that. Sometimes the only thing everybody does is an R pressure. But some people call it a QS.
okay, so it doesn't matter if there's no S wave.
Lead 1, like for instance, her question, like there is no S, right, on lead 1?
There's no S on lead 1.
Okay. And that,
Okay, so I didn't go over this. I didn't go over this the other day like I should have. The electricity starts at the SA node, it comes down and hits the AV node and then hits the bundles, right? And then the septum is activated from left to right. Then this myocardium is activated simultaneously. All this myocardium is depolarized at the same time. When you have an electrode on the surface of the chest, V1, V2, V3, V4, V5, V6, those electrodes are going to record what they see in terms of this wave of depolarization, this electrical wave. Does that make sense? Now, V1 and V2 are looking at the anterior wall, which is that skimpy little thin right ventricle. But it's looking straight through the heart, so it also sees that big, thick left ventricle back behind it, right? So what it's seeing is this electricity coming toward it, and all of that electricity going away from it. That's why in V1, there's a small r and a deep S. In the normal EKG, in the normal heart, V1 shows a small r and a deep S. And then the r gets a little bigger. And the S gets a little shallower. Until you have transition at about V4, where the R wave starts being bigger than the S. And in V5 and 6, you can even have no S wave. Does that make sense? We call that normal progression of the R wave across the precordium. Does it make sense to everybody what these electrodes are seeing and why they're writing electricity coming toward it, electricity going away from it?
Not really.
Does that make sense to you? Is there a question in your mind you want to ask? Or do you want to just try to memorize it?
Okay.
I might be able to answer it, I might not be able to. Sometimes if you ask a question It'll clarify it, yeah.
Similar thing, but back to V1, because that's obviously not a normal V1, because it's supposed to have a small r and deep S, and there's no S. So can you make a conclusion from that?
On EKG 3.
Oh, sorry, number 1. Oh, you were saying V1 is a small r. Deep.
V1.
Gotcha.
V1.
I was confused.
We're just talking about the precordial leads now.
Gotcha, I gotcha.
Small r deep S. Lead V1.
So the R is looking at the right ventricle kind of.
Okay, so here's your electrode sitting up here on the anterior chest. And if you think of the anatomy, on the front part is the right ventricle, and behind it is the left ventricle. Real small, real thick. It's looking straight through.
Got it. So it has seen a little bit coming towards it and a lot of activity going on, which is the little bit. Just the.
Now, what doesn't make a lot of sense to me is that this has all happened simultaneously, but yet there's some time between this and this. So that doesn't make a lot of sense to me, but I let that go. It's not something I can stay awake worrying about. Anything else? Yeah.
I just think people are probably confused thinking that a S wave, since it's going down, is not normal. Instead of knowing the pathology of it coming towards you in a way, I think that's what people are confused about is if they see it going downwards, they think it's abnormal.
Does anyone think that?
No.
Okay. Any other questions there? Let's go to 4. Oh, I'm sorry.
So from now on, even in front of the book, it says like if it has that pattern, it's called ischemia. Do you want us to now
Do you mean the
say?
T-wave inversion?
Yeah. Do you want us to now say primary T-wave changes always instead of ischemia?
No, I don't care what you call it.
Okay.
They're both right.
Okay.
Yeah. I want you to not forget
That is.
that the T-wave flip might be ischemic, and that's what we have to worry about. Usually, we have to worry about that more than mild hypokalemia, mild hypomagnesemia. Where? Yep, what did I tell you to do to AVR? Ignore it. Don't you bring that up.
Is there any way that you could point out the absent Q wave? Because I'm not,
The what?
I think you said in lead 2 there's not a Q wave. But
Right.
I
2,
just
3, and AVF.
wasn't
There's a
seeing-
Q wave in 3 and F, not in 2.
Okay,
There's an R wave.
Is like enough.
okay. It's just a normal. It's just normal, okay.
It's a real tiny r. You see
I
It's
just
tiny
didn't
R.
see
It's
it.
tiny R. It's about 2 to 3 small boxes
Q goes down.
in 2. There's no Q wave in 2.
No, because
It's just a wave.
is the person down after the P.
Anything else? Let's go to 4.
Does everybody understand where to get their baseline? The baseline is not the lines that are on the EKG paper. Your baseline is the patient's baseline. So how you figure that is by literally looking at the straight lines across from one QRS to another, and the most straight that you can line all of those up would be your patient's baseline, and so then draw that line. But once you get the hang of that, you'll be able to see that with your own eyes without drawing it. But
Great
it's the
point.
patient's baseline, not the paper.
Yeah, great point.
Down,
Number 4,
but not so it goes down.
Sarah White.
It goes below.
Yeah, the Q is what goes on.
Oh, it's like right here, below. Okay, that makes sense. I was thinking that little divot was,
That's going back to
I thought,
Okay.
okay.
Be confident.
Strong and wrong, strong and wrong.
Commonly wrong, but never in doubt.
So for the rhythm, I got just a regular sinus rhythm. Heart rate, I got approximately 85-ish. This is where things go south. PR interval, I got 0.09. QRS, I got 0.12. QT interval, I got 0.24. And then for the means of the frontal axis, I got around like negative 30, which would have been a right axis deviation at 30 degrees.
It's the left axis.
Yeah, that's what I meant, sorry.
Yeah,
Left axis
left axis.
deviation. And then I said that there's a negative deflection of the QRS complex in leads 2, 3, and ABF.
What do we call that?
And deer wall.
It's Q-wave.
Okay,
Yeah.
yeah, QA. Yeah, that's all I got.
Go ahead, keep going.
That was all I
How
had.
about the T waves? How about the T waves that go along with those Qs? How do those look? They're funny looking,
Yeah.
in a kind of a funny looking way, as they
Right.
say in Fargo. He was kind of funny looking in a funny looking way. They're funny looking. They're kind of convex, and then they dip down into a negative. So we don't know for sure. Probably what this is an ST segment that's convex and then an inverted T wave. What does that make us think about? Acute, yeah. This makes us really worried. This is a really ugly STT wave. So this is an acute inferior wall MI. Any major discrepancies in any of those other readings? Yeah,
For the frontal axis, I got -60.
yeah, that's what I got too. That's what I got too. Now, if you're just using his method, you get it anyway, right? It's a left axis deviation, and it doesn't matter whether it's -30, -60. Anything else? Yeah.
So I totally read this wrong, but I just kind of wanted to learn how to do that again.
Right.
So I have trouble finding P waves regularly, and so I didn't get the PR, and then to me that kind of looks like a.
Okay, all right. Okay, so anyone else have trouble seeing the P waves here?
I thought it was a non-sinus.
You did. And you thought it was a non-sinus rhythm for what reason?
For the P waves lacking.
Okay, so let's look at lead one. Is there one of these things? I like the way he used this thing, man. I'm surprised he didn't whack me in the head with it. Oh, I'm not as tall as he is. Can you lower the screen for the short internist? There's a P wave. There's a P wave. There's a P wave.
That's AVR.
Yeah, maybe.
I thought you were not.
I'm staying away from that thing. Someone will whack me with this thing. Okay, do you see the P waves now? If you look at them, and if what you do, here's the deal. Your eye will be drawn to some lead when you're trying to figure out this QRS business. And if you're having trouble in that lead, change. Go to a different lead. Even go over to the V's somewhere. Because usually what will happen is that if you're having trouble finding the P waves in one lead, they'll be clearer in another. V1 is usually a pretty good lead to find a P wave. Once you've found them and you're convinced that this is really a sinus rhythm, then you can go back to the limb leads and measure the PR.
Can you show us the P
In V1.
This is the one I wrote no P waves on. It's like,
Yeah, they're hidden.
They're hidden. There are almost no P waves in V1. You just can't hardly see them.
but they're there.
Okay, so look at V1, V2, and V3. Okay? V1, V2, and V3 are being written at exactly the same time. So what's going on in each of those QRSs in V1, V2, and V3 are exactly the same time interval. Okay? So if you look at the second, third, look at V3. Well, in the V leads, in that first three V leads, you don't see much of a P wave. If you look over at V4, V5, and V6, they're completely clear. Now, if you go back to lead one, you see them again? Yeah, now they're clearer. Yeah, so you gotta have to look around. I can't tell you why the P waves aren't very clear in V1, V2, and 3. But if you had one of these calipers, like I used to read these EKGs, and you marked out this R&R interval, it'd be pretty regular. It's not irregularly irregular. It's not atrial fixed. Yeah.
So if you have, since we don't see them in V1, V2, V3, but we do see them in V1, that's enough to know there's a Q wave, we don't have to see them in every single one?
That's true. You don't have to see them in every single one. Yeah.
So
Yeah,
a cheap,
because-
I'm sorry, go ahead, I thought you were done.
Go ahead.
A cheap caliber, to not have to purchase one of those, is a piece of paper.
Interesting.
How we get those?
So get a piece of, blank piece of paper. And I'm gonna use these because these are sharp QRSs, or actually these because there's more. And you lay it on there and you mark the peak of the QRS. And then you take your paper and you move it. And if it continues to fall on, you're regular.
Magic. It's called Tammy magic. Reggio magic. Good.
It's a cheap one.
Cheap
And
caliber.
you can pick a paper towel out of the wall
Yeah.
of the hospital room.
So a technique that I use is that when I glance at an EKG, what will develop is that you'll be able to glance at the end of this course. You'll be able to glance at an EKG and you'll know whether it's normal or abnormal. You know, you'll just glance at it. But that's like sitting down at the symphony and saying, that's a beautiful song, or someone's way out of tune, someone's really flat. And you have to drill down to try to figure out exactly why it's abnormal. If you start looking for P waves on this EKG in V1, V2, and V3, you're not going to see them. And if you did that, you'd say, well, there's no P waves, this must be a junctional rhythm. This must be coming from the AV node if there are QRSs but no P waves. And junctional rhythms are regular. Because if the junction, I'm calling AV node, just the junction. If the rhythm center is the AV node, that'll be a regular rhythm. But before you jump to that, that's a really unusual finding. Before you jump to that, you start looking around and you start seeing P waves. And, oh, okay. Mostly in this EKG, there are P waves. Yeah. Okay.
I have a question.
Yes.
On V1 and V2,
Yeah.
I don't know if maybe my eyes are trained up, but they kind of look like Q waves. Like, is the up just masked by the line that it's going?
Maybe
on?
so. Maybe so. I see the R waves clearly in V1 and V2.
Okay. Yeah, because it just kind of looks like I don't know, especially like in V2, it just kind of looks like a thickening of, I don't know, maybe if it was,
There are R waves.
there are always.
Does anyone else see Q waves in V2? You do?
Yeah.
So kind of, maybe that up is just on a line and it's just making
Yeah,
it.
part of that's because of the fuzziness of this. All right, anything else on this one? Number 5. Shannon?
I had a normal sinus rhythm, a heart rate of 75, a PR of 0.24, a QRS of 0.08, a QT of 0.36 with left axis deviation, and first degree AV block, and old infarct in both septal, lateral, and anterior.
You found infarct where?
In the septal, lateral, and anterior.
So what leads? Are you saying you saw Q waves?
Yeah, in V1, V2, V3, V5, and V6.
Okay, let's look at V1, V2. Does the first thing that happens in the QRS go down or up? Up. It goes up, goes down, goes back up, what do we call that?
Bunny ear.
Bunny ears.
So right bunny brain.
There's rabbit ears in V1. This is the most recognizable finding on an electrocardiogram. It doesn't always mean right bundle branch block, but it almost always means right bundle branch block. So, as it turns out, okay, if we think this is a bundle branch block, now we've got to go rethink the QRS. Did anyone find a QRS in the limb leads that was greater than 0.12, or at least 0.12?
I got point one.
I
got point one too.
Where was it?
Now that I'm re-looking at it, I don't know which one it is.
Yeah,
Probably an ABF.
I got that
Yeah.
You got it as 0.16. So this is a right bundle branch block, and the QRS is not greater than 0.12 in every lead, but there are some leads in the limb leads where it's greater than 0.12, and that's all you need. What you really need for a right bundle branch block is rabbit ears in V1. There's one exception to that, which we'll see later, but this is a right bundle branch block.
In V1 and V4, are these depressed ST?
They're inverted. In V1, the T wave is inverted. Everyone see that?
Inverted ST.
Was the question, is this anterior ischemia? Or was there no question? Okay, so here's something brand new for you. The T-wave rule changes. T-waves that are inverted, we call them primary T-wave changes. Right? And primary T-wave changes can be caused by ischemia, hypokalemia, hypomagnesemia, pericarditis, increased intracranial pressure, a variety of things. But if the T-waves are changed and they're secondary to something else, they're not primary T-wave changes. They're just normal. Bundle branch blocks are one of those circumstances. If this is a right bundle branch block, this T-wave, the T-wave in a bundle branch block should be opposite in direction to the last portion of the QRS. That's what it should be. That's a secondary T-wave change, and it's appropriate. It's just a rule change for bundle branch blocks. If I had tried to give you all this yesterday, day before yesterday, would have been too much all at once. So we give it to you a little bit of a time, little bites. So this is a secondary T-wave change. Here's a left bundle branch block in P6. There is the last portion of the QRS. There's the appropriate T-wave flip. Okay? So this is a bundle branch block. This is, what is the axis here? LAD? Yeah. Question?
Do you see a prolonged PR on, like one, well, really like 3?
Well, my PR interval is 0.24. That's too long. So what is that called? First degree AV block, primary AV block. Everyone get a primary AV block on this? Yeah. This is the first degree AV block.
No.
What lead did you do that?
I'm sorry?
What lead were you looking at the PR? Any of them?
Definitely in lead.
Definitely in lead AVF. Definitely lead 3. Definitely lead 2. 2, 3, and AVF all have prolonged PRs. So this is a first degree AV block and a right bundle branch block and left axis deviation. Number 6. Cassidy.
Okay, so on this one I got normal sinus rhythm, heart rate of about 80, PR of 0.12, QRS around 0.08, QT 0.36. In the axis I got positive 60, so normal. And then that's pretty much all I had. This one looked fairly normal to me.
Anybody find anything abnormal about the CKG? I I call it a normal EKG as well. So mean. So the way I designed this course is, it's as if you were sitting in a heart station at Baptist Hospital and you were reading all the EKGs for the day. This is exactly how it happens. They just come at you. Sometimes they're normal, sometimes they're not. And this will teach you how to read EKGs a lot faster than if I systematically go through all these things. Okay, number 7. Kathleen McKenzie.
Well, this is the one we did together for the practice, but, so I didn't do I see now that it's sinus rhythm.
It's sinus,
Heart rate 60, PR 0.2, normal PRS, QT between 0.28 and 0.4, normal axis, and then inverted T waves on V1 through V4. So that would be septal, anterior lateral, or anterior left ventricle, septal.
Primary. So it's aneroseptal what? Huh? Ischemia. Just flip T waves. It's either primary T wave changes or aneroseptal ischemia. Anything else?
I might be wrong, but I thought possibly pre-excitation syndrome,
Okay.
depressed P wave.
And where did you see the short PR interval?
Maybe one, no.
Lead 1 probably.
Lead 1, yeah.
Lead 1. Lead 1 is really close. I think that's a good pickup. Lead 1 is really close. It's probably 0.12. It's probably not quite short enough. And then if you remember what Jacob said yesterday, for a real WPW, you see this delta wave. You don't always have to have it. If the PR is too short, if you want to call this pre-excitation syndrome based on lead 1, I'd say power to you.
Would it be close in lead 3 also? Because it's similar?
Well, let's see.
Is the R
It'd be close. I would call it 0.13 and lead 3. So here's one of the things I do. This isn't fair, but I do it anyway. I look at lead 1 and it's, boy, that's close. I look all the rest, I look over everywhere else on the EKG. I never see a delta wave. And in every other lead, the PR is a little greater than 0.12. So I call it 0.13. I call it PR 0.13 and go on about my business. I don't call this a pre-excitation. But if you call it a pre-excitation, based on lead 1, it wouldn't be wrong. All right? It'd be a more conservative reading. So if you're a Republican, it'd be the way to go. How about anything else on this one?
I put that it was ischemia because I saw convex ST waves.
Where?
In V1 through V4.
V1 through V4, the T waves are flipped. So this is either anerolateral ischemia or primary T wave changes in the anerolateral leads, right?
Mm-hmm.
Anything else?
I just put ischemia instead of injury.
You put injury
I mean, I put injury instead of ischemia.
instead of ischemia.
Yeah.
We're not going to have a fist fight about that.
Okay.
The ST segment's a little bit concave in like in V2. It's not elevated off the baseline, but we're not going to fight about that. Anything else? How about that Q wave in lead 3? This is an exception to the Q wave rule. I said if you have a Q wave that's greater than 0.04 wide and 0.04 deep, it means incline. Unless it's isolated in lead 3. So an isolated Q wave in lead 3 is a normal finding. What do I mean by isolated in lead 3? Its siblings don't have it. Lead 2 and F. Number 8. Oakley.
Okay, so on this one, I found that it was sinus bradycardia. I had a heart rate of 55, PR of 0.16, QRS 0.04, QT 0.36, and my axis was normal. And that's what I found.
And so the only thing you found was sinus brady?
Yeah.
Anyone find anything else?
So are those T waves not peak on my V2, V3?
All right, so V3, V4. Okay, so yeah, they are a little peaked. How do we worry? What do we do about the peak T wave? Well, don't know. I worry about T waves if I don't want to sit on them. Jacob said the first thing that happens in ischemia is a peaking of the T wave. Maybe that might be this. Now, T waves that are too tall, I think a lot of people use some sort of a reference like they need to be at least half as tall as the R wave they're next to. And these are a little bit less than that. But if you want to call this peaking of the T waves in V3 and 4, we're not having a fist fight about it. They look a little abnormal. I don't know what in the world it would mean, but it might cause the clinician who's taking care of this patient to wonder about it and look for things that cause peaking of T wave.
So they need to be dramatically peaked.
Well, the criteria I use is that they need to be at least half as high as the R wave they're next to. And we'll see some of those before this 80 is over.
I had that it was off of the baseline, the ST segment leads V2 through V4, just because the P is so much lower. I drew my baseline lower.
Well, it is a little off the
It's
baseline,
concave,
yeah.
So it's,
Yeah, so in V2 and V3, is that where you're talking about?
yeah, 2, mainly 3 and 4.
Yeah. So if you look at V3, this is why I said yesterday, on Wednesday, I said something exactly opposite of what Jacob said, didn't I? Look at V3. See that? Here's your P, QRS. The ST segment takes off a little above the baseline. Jacob said, if you see an EKG where the ST segment is elevated, get a consult. Ask a cardiologist. Get an overreading. That's not bad. That's not a bad idea. I mean, you're going to be a second-year PA student. You can't be making decisions about sending people home who might have a heart attack. So at least get an overreading. Have the ER doc read it. Have your attending read it. Have the resident read it. Okay. I said, don't worry about elevated ST segments. Worry about convexity and concavity. Now, if you do that, this is an ST segment that's concave. Is there someone coming in here at 9 o'clock?
Nope, 10.
Oh,
You're good.
we're going to be screwed away, aren't we? This is an ST segment that's concave, right? So for me, this is an okay, this is not an ugly picture. Now, the problem with that is that he showed you some EKGs yesterday that look like that. ST segment's way elevated, the ST segment's concave, and he said, this is a STEMI. They're having a heart attack, get them to the cath lab. So he said something exactly opposite that I said. Now, I also told you that this is harder than measuring the PR, QRS, axis, and all that stuff. And it is because this is an ugly as hell picture. This one, not so ugly. How do I know that? Because I've been doing it for 35 years. You'll learn it too. Jacob would not call this a STEMI. But it violates what he told you. Does that make sense? So if you recognize that the ST segment is elevated here in V3, you would be exactly right. The most, and Jacob said this Wednesday, the most common cause of what you're seeing in V3 is early repolarization. What do we mean by that? We mean, as he said, the wave comes in, depolarization, the wave comes out, repolarization. If when the wave's coming in, you're writing a QRS, and when it starts coming out, you're starting to write the ST segment. What's happening in V3 is the ST segment's beginning to be written a little early, before the R wave gets back to the baseline. It's called early repolarization. Does that make sense? How do I know that from STEMI? I don't know. I've seen it a million times, not a million. I've seen it 476,382 times, or something.
Clinically though, it's only in one lead. It's not in all contiguous leads. As well as you're going to correlate your clinical symptoms and the picture of your patient. That's why we don't treat EKGs.
Okay, that's a great point. He also made the point of contiguous leads. This isn't present in any other lead. There's nothing contiguous. There aren't any brothers and sisters. There aren't any cousins playing this same tune, right? And if this patient was having chest pain, you might worry about that, and you'd get it overridden by someone.
Is there not elevated T waves in V4 too?
Is the ST segment above the baseline in V4?
Are you saying peaked T waves?
Oh yeah, same. Well, yeah, they're peaked in V3, V4, V2.
So those would all be early repolarization?
No, the peak T waves are not early repolarization. Early repolarization is this notch right here. This notch where the QRS stops and the ST segment begins. It begins a little early. It's supposed to begin right here at the baseline, but the QRS doesn't have quite enough time to get down, so it starts a little early. Other questions? So there aren't any dumb questions. Everybody has all kinds of questions. What in the world am I doing here? But this will get faster and clearer as you go on. Number 9. Oh, look at that, 8. So there's some notes here. We need to pay attention to these. Inverted T waves usually mean primary T wave changes, commonly indicative of ischemia.
He went back to 8 if you're lost.
I'm back to 8, guys, on these notes over here. Exceptions to the T wave rule. If the T wave is inverted in lead V1, and that's isolated, it's not inverted in V2, it's normal. And then T waves are commonly inverted with T waves. So the rule for T waves changes in bundle branch blocks. We just talked about that. Okay. 9. Gracious. Jessica.
She's not here.
She isn't. Ryan.
Yay. This one was fun. It's ugly.
Yeah.
I had trouble measuring things on this one, but I did get atrial flutter as the rhythm. And the rate was 175. Measuring P to R, I was going to ask you about, because it was really hard to identify a P, or was it just a T? I wasn't sure.
Okay, so that's a good pickup. So look at lead 1. You see there's a hump before each QRS. The question is that a P wave? Right?
Right.
That's your question.
Yeah.
And you look around the rest of the EKG, and you can't see them anywhere. So so there probably aren't any P waves here. What is the QRS interval?
I put 0.16.
You got 0.12.
Yeah.
Okay, Tammy, get your piece of paper and draw the baseline. Not in 1. Let's use AVL. She's gonna see if she can find. There you go. There you go.
Oh.
See that baseline? Now she draws a line across that. Now she can sort of orient herself about what's what. Okay, now we're cooking with applesauce. There is a little bump before the QRS is there, but let's worry about if you use that as the baseline, what's the QRS interval? Huh? It's really wide. How wide? All we have to get is wider than 0.12. It's too wide. It's really wide. 0.16 or 0.20. It's wide. Okay, what does that tell us? A wide QRS tells us one of two things. What's the first thing a wide QRS tells us? It's a bundle branch block. Or, the second thing it tells us is what? What?
Left ventricle hypertrophy.
Man, I cannot hear it.
Hypertrophy.
Hypertrophy. Not so much. Hypertrophy causes amplitude of QRSs, not width. It tells us, yeah,
Ventricular origin of rhythm.
yeah, a ventricular pacemaker. There's something. The pacemaker's not coming from the sinus. It's not coming from the AV node. It's coming from the ventricle. So if the pacemaker's coming from here, it spreads out in all directions, and the only way you can get it to the right side is it has to go through the myocardium, so it takes a long time. So this is either a bundle branch block or a ventricular rhythm. He said it was 180. Is that too slow or too fast? Too fast. So by definition, what's the rhythm? Ventricular tachycardia. Yeah, by definition, this is ventricular tachycardia. What do? Shock. Well, not so quick.
Oh.
I almost said something Wednesday because Jacob said, he showed you this, he said, shock him. Not so quick. I'm your patient. I'm in the ER. You're standing at my bedside. I have chest pain. You've slapped an EKG on me, and this is what you get. Say, Dr. Vanatta, how are you feeling? I said, well, not so good. I'm having chest pain, a little short of breath. Let me tell you something. You come at me with those patterns, and you're going to get your jaw broken. Because I know how that does. Now, I know this is a dangerous rhythm, but I want you shocking me with the goddamn paddles. So there are shockable rhythms. What's the problem with this rhythm? The problem with this rhythm is it's unstable, and it's liable to turn into ventricular fibrillation quickly. So Dr. Vanatta might be laying there in VTAC, and 45 seconds from now, maybe in VFib, and 1 minute from now, maybe dead. So this is an emergency. But it's not an emergency enough to shock me awake. Okay?
Keyword awake.
Keyword awake. Keyword awake. If I'm unconscious, you shock me. No question about it. This is a shockable rhythm. But if the patient's awake, you've got time to get some help. Get that attending over there. What do we do? Attending don't know what to do. Yeah.
Can you go over the definition of ventricular tachycardia again?
The pacemaker is in the ventricle. So we go back to your first question, which was, are there P waves?
Okay.
And lead one is the only one where you might even consider this.
Okay.
And they're not, those are T
So we
waves.
know just not having P's, it's ventricular.
Right.
And then
Right.
by the rate, we know it's tachycardia.
Yeah, it's too fast, it's too wide, and there are no P waves.
Okay.
That's ventricular tachycardia.
That's too far.
Okay. A ventricular rhythm ought to be 20 to 40.
Right, okay.
This is a ventricular rhythm that's 170. Yeah.
I have a sinus rhythm question.
Yeah.
I'm just a little confused over what the definition of that is. I see that this is a regular range, but there's not a P wave,
Yeah,
so
yeah.
is that sinus or not?
No, it's not sinus, it's ventricular.
Because,
Because there's no
because
P's.
of the got it. Yeah.
Huh?
So what are the, if there was not,
It's not, they're shading, it's conventional.
Yeah.
Can it be a sinus rhythm with a long QRS? Does that ever happen?
Yeah.
Remember that?
Okay.
They're like slow.
Yeah. Yeah, that's called idioventricular rhythm with aberrancy.
So, you know, it's ventricular.
I'll remember that.
And those people usually be awake.
Yeah.
And your attending will probably know it. Your attending will say, whoa, 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 wait, you can't shock him, he's gonna be pissed off. This might be idioventricular rhythm with aberrancy, so let's be careful here. We might need to, so you can do a variety of things. You can double the amplitude of the EKG machine so that this thing the picture gets drawn out a little more and you can see a little bit more. If you wind up convinced that this is VTAC and you need to get them out of it, you can sedate them and shock them. No, your attending can sedate them and shock them. You might wait, see what happens. I was once in the ICU as a senior medical student, so this is back in the dark ages. We had monitors, but we didn't have anything else, really much of anything. We had quinidine, which killed people, but a lady was laying in there. She'd been admitted because she had chest pain. She's laying in there, and my attendant and I walk in, and we walk up to the bedside. We're standing at the bedside, and her rhythm does that all of a sudden. She suddenly goes into ventricular tachycardia, and she had been talking to us, and she fell unconscious. My attending pounded her on the sternum, gave her a precordial thump, scared me to death. Her eyes popped open, and she said, "Don't you ever do that to me again." I mean, I thought, what in the world? This is in fact the best educational experience that anyone can do. I mean, where else would you see that? A man slugs a woman in the chest. And she says, "Don't you ever do that to me again." And no one gets arrested. She was unconscious, but she was just getting unconscious, I guess. And we were just standing there and watched this rhythm happen. And she went right back into a sinus rhythm. It was, I thought he was mad. Okay. Any other questions about this one?
So does the atrium pump
The atrium pump. You know, I don't know. I don't know the answer to that. Probably not. I would guess that the ventricles are overriding it somehow.
I wish I got some questions. No. I did my
The reason this is unstable is
My
two
picture's
reasons.
wrong.
Number one, it can degenerate into ventricular fibrillation, which is lethal. And number two,
Did you get it in the
the cardiac output is going to be decreased because the heart doesn't have time to fill. When it's going 170 times a minute, it doesn't have time to fill from the atrium. So your cardiac output's going to fall, and you're going to be decreasing perfusion to the brain, the kidneys, and all the vital organs. That's why it's
Is this like hands down VTAC, or like could you possibly see some P waves and call it sinus tach, or is it like the perfect picture?
No. If this is not VTAC, it's idioventricular rhythm with aberrancy.
Oh, okay.
Now, what do I mean by that? I mean that the electricity is coming from the AV node, but there's also a left bundle branch block. So it's AV nodal tachy with an aberrant conduction in the ventricular muscle. But it can't be sinus tach because there aren't any P waves.
Now, how do you know it's a left bundle branch block here?
Oh, I don't. I'm
Okay,
just,
so that was a difference.
it could be right or it could be
So
left.
this is just generically a bundle branch block.
It could be just, well, no, let me back up.
How would you tell that?
What did you see? Are you talking about V1?
Lead B1 and B2, lead B1 and B2,
Or is that?
I could argue is a right bundle branch block, and I could argue that B6 is a left bundle branch block. But
I
if
didn't know.
B1 and
I was
B2
gonna
are a right
ask, but
bundle
I
branch
didn't
block,
wanna
there has to
know.
be a posterior myocardial infarction. But we'll get to that later, we don't have to worry about that. Yeah.
Okay, another question. I have that the T waves are absent on lead 2 and AVF. I don't know if that's right or wrong, but
Okay, all right, so look at lead 1. Ryan was worrying about initially are those P waves before each QRS? Or what are they? They're probably T waves after the QRS. They're probably T waves, they're not P waves. And this rate is so fast that the EKG is having a hard time writing T waves. The myocardium, Jacob told you about this yesterday too. The myocardium is having a hard time repolarizing. It's coming so fast. And you have the reason it develops into ventricular fibrillation is the wave comes in and the wave comes out. This one's coming so fast that the wave comes in and comes in again before the wave comes out. So you don't get T waves.
okay.
And when you have a crashing of the waves like that, you can develop VFib.
Oh, okay. Okay. Help me out.
Chaos. AFib and VFib are chaos in the myocardium.
So we haven't quite gotten to that point on this EKG.
Haven't gotten that point yet.
Just know this is a precursor of that rhythm.
This is
If you don't
really
do
ugly.
anything, it's gonna go into VFib and your patient's gonna die.
That's the rule. VTAC turns into VFib. That's the rule.
Just one more question. If the ventricle's controlling, normal AV node would be 40 to 60, right? So why is this going so fast if the
Well,
ventricle's
if it's nodal, it'd be nodal tachycardia. It would be
Oh,
the node too fast.
okay.
So if they're awake, you can shock them in one.
You ask your attending with you. Well, I don't know. He or she might sedate them and shock them. No. He might say, I don't think this is VTAC, I think this might be idioventricular rhythm with aberrancy. Let's turn up the gain on the electrocardiogram machine and get a bigger picture. He might say, my favorite cardiologist, if you're in the ER, he or she might say, my favorite cardiologist is up in the CCU, and he calls up here and says, would you come down at this EKG, because this guy's wide awake and stable, blood pressure is normal.
You'll learn that in ACLS.
And, you know, he's laying here in my ER, his blood pressure's normal, he's awake, and he's got a really dangerous looking EKG. And on top of that, he's got a top of the EKG. Did you come down here and look at this?
Let's show you.
I'm wanting to shock you. But, okay, any other questions? So there again, you've got a difference between reading the EKG and doing something in the ER. They're different. That's where STEMI comes in. And when you take ACLS, that algorithm of what to do with VTAC will come in. You'll ask the question, right? Are they conscious? Is their blood pressure stable? If they're hypotensive, if their blood pressure is unstable, then you better act fast. But someone else will have to be doing the acting for a while. So Tim, let's see. This would be Jenna.
I got normal sinus rhythm, heart rate 75, PR 1.12, QRS 0.04, 0.40 for QT with a left axis deviation. There was inverted T waves in V1 and 2, I think, which is anterior ischemia and strain patterns.
What was your axis?
Left axis.
Okay.
I got borderline.
Yeah.
I got like negative 25, but you said negative 30 is left, so.
Yeah, so, yeah. So my criteria were different than Jacob's. He had this entire thing. You know, it just depends on what author you want to believe. So it's left axis, it's right bundle, it's a right bundle branch. Anyone else get a right bundle branch?
Right?
Okay, so explain what you saw in this that made you think it was a right bundle. Bunny ears. Look at V1. Man. So this is what it looks like, right? So the R is tiny, there's no S, and there's an R prime. You see that?
Splitting in V2.
What is V1 supposed to look like, even with a right bundle branch block? Look at this. Look at all this. It's gone. It's gone. The QRS is too wide, so we know there's a bundle branch block. There are rabbit ears in V1, so we know it's a right bundle. But why does V1 look so bizarre? There's no S wave.
Oh, this one. So look at.
Okay, so this is a logic issue. Here's V1 looking straight through the heart. Straight through the heart. And all it sees is electricity coming toward it. It sees no electricity going away from it. Where would the electricity be going if it were going away from it? Huh? Left ventricle, what portion? What part of the left ventricle? Posterior wall. Now we don't have an electrode on it. There is a VB. There is an electrode. You would put 1, 2, 3, 4, 5, 6, and then you'd put VB back here, and you'd get another picture of the heart the other way around. But we don't put that on there. What we do is we say, there's no S wave. Where in the world is it? It's gone. Holy moly. So this is a right bundle branch block, and because there's no S wave in V1 or V2, and almost none in V3, we worry about a posterior wall infarct.
That means it's not sweeping with the other side.
Does it mean what?
On your picture there, then it's not able to get over to the.
Okay, so this picture
Or the other one.
is a two-dimensional picture that doesn't show the posterior wall. We can't even talk about the posterior wall in this picture. So you have to worry about a posterior wall infarct simply by the absence of any posterior forces. There are no posterior forces on these V leads.
So no S's in the V leads is that?
I didn't say that. No S's in V1 and 2 is bad.
Okay.
Is that always or just in the right bundle branch block scenario?
Okay, so let's go back. Let's go back, since we've got a little time. Let's see if we can explain this a little better.
Hey, I'm going top left. Do I have to know this?
So it's literally
Okay, you ready? V1 is supposed to see a little bit of electricity coming toward it and a lot going away from it. V1 is supposed to have a small R wave and a big deep S. Everyone understand why? V2 should have a little bit more of an R wave and a little bit less than of an S wave. V3 and V4 might be about equal. V5 should have more R and not much S. V6 might be mostly R wave. That's the normal transition of the forces, anterior forces and posterior forces across the corpus. Now we can talk in 3 dimensions because these are electrodes looking through the chest. Anterior forces, posterior forces. The posterior forces, lateral wall forces, and posterior forces are these S waves. Especially in the anterior leads. So, what if V1, let's just use this and let's just use our logic. What if V1, which is supposed to look like this, looks like this? What are the 2 things that we could hypothesize might cause that? 2 things.
Right ventricular hypertrophy.
Great, right ventricular hypertrophy. The muscle on the right ventricle is too big and thick. So the anterior forces are overriding the posterior forces. RVH, right ventricular hypertrophy. And there's a second one. What is it? The electricity going back in the ventricle is gone. What causes that? Infarct. Infarct. Posterior infarct. There's too much anterior force, or there's not any posterior forces. One of the 2 things is going on to cause that abnormal QRS and V1.
Did you say that was a right bundle branch block?
It's a right bundle.
How do you tell the difference between right and left? I'm still confused on that a little bit.
Okay, there are 2 ways. Look at lead V1 and V6. In V1 in a right bundle, you should see rabbit ears. In V6, you should see the electricity going away from V6 late in the QRS.
So the S.
So here we are, electricity's coming down the AV node, right and left. The right's blocked. So we can't get any initial activation of the right ventricle. what we see initially is the septum being activated in V1, this right bundle is blocked. So V1 sees this septum activated there. Does that make sense? Since the then it sees the ventricular activation through the left bundle going away from it. Does that make sense?
Yeah.
And then it sees the electricity coming through the myocardium late in the QRS, and that's R prime. V6 sees maybe a tiny little Q wave, but usually not. It sees most of this activity coming toward it. And then late in the QRS, it sees activity going away from it. So when you know there's a bundle branch block because the QRS is too wide, you'd look at V1 and V6. If in V1 you've got RSR prime, it's probably a right bundle. And to check that, you look at V6 and see if the activity late in the QRS is going away from it. In this one, it is.
So you'd see an S, a pretty big S wave in V6.
Yes.
Okay.
Yes.
And so how's it different from the left?
Okay, so let's just do the left side. What I would recommend you do, if you study in groups, sometime this weekend or next week, is get in your group and one of you say, someone needs to stand up and explain the right and the left bundle. You go through this same process, okay? It'll clarify. All right, now you've got the right bundle, which is normal, but your left bundle is blocked. The septum, this is a key, the septum is activated off of the left bundle. But if it's blocked, it can't get activated. So it gets activated off the right bundle, so your septal activation is backwards. And since the left bundle is blocked, this can't get activated. So now you've got this activated, and the left ventricle gets activated through the myocardium. So V1 sees electricity going away from it, coming toward it, and going away from it. V6 sees electricity coming toward it, going away from it, but not too long because it's such a wimpy little muscle, and then late in the QRS coming back toward it. V6 might look like this. The key is the QRS is too wide, so there's a bundle branch block. Now we've got to figure out, is it right or left? And if there's a big deep S wave in V1, and the activity late in the QRS is all above the line, it's a left bundle.
Okay.
All right. Other questions that bothered you? Yeah.
Is there an injury pattern in the Atrial?
Great question. Okay. Great question. All right. In bundle branch blocks, depolarization is abnormal. Right? It's always abnormal. The depolarization wave coming in is always abnormal because it's not coming down the electrical pipelines. The majority of it is spreading out through the myocardium, which makes it longer. QRS is wide. So most of this depolarization wave is just sort of spreading out through the muscle fibers. Cardiac muscle is different than bicep muscle. The bicep muscle has to receive an electrical innervation from a nerve coming out of the spinal cord. The cardiac muscle is a different kind of cell. Every cardiac muscle cell can also act as a neurological tissue, which is why you can have idioventricular rhythms and ventricular rhythms. If the SA node fails, the AV node fails, the ventricle can take over. It just does so at a slow rate. It can take over because the muscle cells can act as neural cells. That makes sense? Nature's pretty cool. It builds in some pretty cool takeover stuff. Okay? So what has happened here is that, I don't even know why I started on that. What was the question?
Was there an injury
Oh, is there an injury? Okay, so the depolarization wave is abnormal. Therefore, the repolarization wave is abnormal. So if you have a bundle branch block, you can't jump up and start worrying about ischemia and injury. It's really true for the left bundle, but it's kind of true for the right bundle. Injury and ischemia is harder to call with the bundle branch block.
We said in V1 and V2, the ST segments were depressed. And in our book, it just says ST segment depression. It doesn't like link anything to it.
Yeah.
Okay, so you're talking about V5 and 4 and 5?
Well, it's V1, V2, V5, and V6 is what we saw depressed ST segments.
Oh, I see. Yeah.
But in our book, it just says depressed ST segments and it doesn't link it to anything.
Well,
That's fine.
what I just said was, in bundle branch blocks, repolarization curves are abnormal because of the bundle branch block. T waves are sometimes flipped upside down because they're opposite in the last portion. See, if this were the QRS, the T wave would be upright. If this were the QRS, the bundle branch block, the T wave would be bottom. So you can't read ischemia and injury pattern into EKGs with bundle branch blocks. It's just not reliable.
So if it was a normal one without a bundle branch block and you had a depressed ST segment, what could that mean?
Could be a lot of things.
So in our conclusion, like just putting depressed ST segment was.
Depressed ST segments, okay, so for me, depressed ST segments are a little bit like elevated ST segments. In and of themselves, they don't mean much to me. I don't get all bent out of shape if this is a heart attack or if this is ischemia. Now, if your patient is in the ER and they're complaining of chest pain that sounds like heart attack or ischemia, and they have ST segments across the anterior precording that are depressed, you gotta worry about it. But if all you're looking at is an EKG, there's a 1 or 2, you can say depressed ST segments, but you can't say much else. You can't call it heart attack, you can't call it injury pattern. You can call it depressed ST segments if it bothers you. Other questions? Yeah.
So in V2, I'm seeing, I think I'm seeing multiple P waves. Like there's a few candle hooks there.
Okay.
Yeah, I put infant. Yeah, and a newborn. And 2. That one just really.
Can you show me where?
They're really tiny, but.
Okay, so she's looking at the interval between the first and second QRSs in V2. And she sees everyone can see where she's looking? She sees the PQRS. You're looking at lead 2, not V2, right?
V2.
V2? Oh, okay.
There's it's like a depressed T segment and there's like 3 little.
Yeah, I see it in
Yeah.
V2 as well. I see it, yeah, V2 is
Let me
right
see
here.
if
I
I
see it.
can, let me see if I
It's
can
like here.
draw that.
Over a little bit more, so we do, one,
To the
the
left.
other side.
Right there.
Left of your V2, it's like 2.
Right
that
there.
one.
So you're looking at, is this V2?
Yeah.
You're looking at this as a P wave and wondering if that's a P wave.
There's
Correct.
one in the middle.
Yeah, there's one right in the middle.
And that one?
Yeah.
so that's like we ran into a little earlier. So that would be bad. That wouldn't be bad, but that'd be atrial flutter or something with a block, right? So look around the EKG in general and see if you see recurrent P waves between QRSs.
I see it in lead
What?
2
Lead one.
and
V1?
3.
Lead one.
V1?
Lead 1
Lead one.
and lead 2, I think.
And lead two, yeah.
I see it better in lead 2 than I do. Yeah, lead 2.
Jacob said this the other day, but didn't follow up on it. In lead one, I think what you're seeing is is that what you're looking at? And you're what? And you're worried about this as a second P wave? This clearly is a P wave. This clearly is a P wave. Okay? It's most likely a U wave. So P waves ought to, P waves, U waves are repolarization waves. And some authors say there's always a U wave. You just can't see it sometimes. I don't even worry about U waves. I don't look for them. I ignore them. I don't look for them. P waves ought to have, if you have atrial flutter, the P wave morphology ought to look the same. And this doesn't look any, these don't look alike, so it's something else.
So what about?
It could be that the guy hiccuped or something, but it's not an extra P wave because it doesn't have the same morphology.
How do you differentiate between AFib and AFlutter? Is it just AFlutter is more regular and
Yeah.
AFib's kind of?
Atrial flutter is more regular.
Okay,
It's usually always the same rate.
okay.
If you're in atrial flutter through the whole EKG, and let's say you have a 4-to-1 block, then you have a rate of 75. Remember him talking about atrial flutter rate is always 300? So ventricular rate's either going to be 150, 75, 60. It's going to be multiples of 300. And so in atrial fib, although there might be some things that look like P waves, the ventricular response to atrial fib is irregularly irregular. It's not regular. The exception to that is that sometimes in atrial flutter, you can change the block. It'll be 2-to-1, then it'll be 4-to-1, then it'll be 3-to-1, then it'll be 2-to-1. And so this rate, the ventricular rate changes, but it's always a multiple of 300.
Okay. Thank you.
In atrial fib, it's irregularly irregular. Anything else? Okay, 10 more for Monday.
What are you doing this weekend?
10 more, whatever that is. 11 through 20.
This weekend's gonna be nice.
Oh, I want to make a comment. I asked Jacob the other day about QT, and I told you that the QT interval varies with rate. And I generally just don't pay much attention to it. He was pretty jacked up about the QT interval, right? He was jacked up about the QT interval because a long QT interval can kill you. Especially if you're on a medicine that widens the QT interval, and then you put them on an additional medicine that really widens it. Now you've got a problem where you might have the wave coming out, crashing into the wave coming in, and you might go into VFib. That can kill you, right? So he was kind of jacked up about it. Well, I asked him, what, instead of having to carry around with you a table that tells you what's an appropriate QT interval according to rates, he said 44 in men and 47 in women. I would put that number in your cortex. Every QT interval we measured today was less than 44. We'll probably run into some that are greater than 44. We don't know if these are men or women. So if it's greater than 44, I would probably call it a long QT interval. It's good to know that there's a number you can kind of keep in your hip pocket to get worried about. Anything else? I'll see you in
We'll just put it on here and it'll be like that. 6. Do what? You don't have to go 5 or 5. So that's those little. You can do it like super quick. Just put it where it is, put it on. Yeah. And we'll take it. And then like last night, it went so quick. Thank you. I was like,
That's fine, I'm not gonna.
Because like 44 is like 104.
no, you multiply.
No, that's fine.
Like 11 times.
You just said it would be one, but.
Really?
Oh, you see it.
About.
Okay.
That's what a word day.
Okay, so I tried to calculate the
Hey guys, those of you that are still left, I made a mistake on Wednesday when I was talking about Q waves. I said to be a significant Q wave, it has to be 0.125 or 0.128. It's 0.04. I just misspoke.
And then we're picking up on
So
that.
0.04.
Today we talked about 0.04, but I misspoke it on Wednesday, so you probably wrote it down wrong.
Yeah, so.